Hello, everyone. My name is Shruti Gupta, and I am Director of Onconephrology at Brigham and Women's Hospital at Dana-Farber Cancer Institute in Boston. Today, I am pleased to share our new manuscript entitled The Development and Validation of a Risk Model for Predicting Contrast-Associated Acute Kidney Injury in Patients with Cancer, Evaluation in over 46,000 CT scans. Now, contrast-associated acute kidney injury, or CA-AKI, is a well-known entity occurring within a few days of exposure to iodinated contrast media. The literature on CA-AKI is controversial, but we do know from data from animal models that CA-AKI can occur secondary to renal vasoconstriction as well as direct tubular toxicity. Epidemiologic studies also suggest that CA-AKI is associated with a higher risk of CKD, the need for renal replacement therapy, and death. Most risk prediction models for CA-AKI have focused on patients undergoing percutaneous coronary intervention. But patients with cancer may be uniquely predisposed to CA-AKI, given that they undergo frequent CT scans for cancer stage and treatment response monitoring. They may also be uniquely predisposed to CA-AKI due to a decrease in effective circulating volume that can occur for many reasons. And so we sought to develop and validate a model for predicting the risk of CA-AKI after contrast-enhanced CT in patients with cancer. We conducted a search of two independent large data registries for radiologic imaging tests that were performed between 2016 through 2020 in adult patients with cancer. We included data from three major academic centers in Boston. We excluded modalities other than CT, those lacking a cancer-related ICD code, carcinoma in situ or non-melanoma skin cancer, CTs performed without IV contrast, those lacking a baseline or follow-up serum creatinine, as well as those associated with patients with end-stage kidney disease. We also extracted detailed data on demographics, type of malignancy, outpatient medication use like diuretics, and nonsteroidal anti-inflammatory drug use, baseline laboratory values, as well as comorbidities. We defined CA-AKI based on modified KDIGO criteria as either a greater than or equal to 0.3 milligram per deciliter increase in serum creatinine from baseline to a value obtained within 48 hours after the scan, or a greater than or equal to 1.5-fold increase in serum creatinine from baseline to the peak value obtained within 14 days after the scan. The analyses were conducted on a per scan rather than per patient level because numerous study variables like patient age, medication use, baseline EGFR, those things change over time. We used generalized estimating equation models to develop a multivariable model that accounted for correlated data. And we then derived a risk score in a development set that was comprised of a randomly selected 2/3 of the overall sample, and we applied this to a validation set consisting of the remaining 1/3 of scans. Discrimination was assessed based on the C statistic and calibration by the Hosmer-Lemeshow test. And so this diagram shows the flowchart of inclusion of scans after implementing all of our exclusion criteria. And so ultimately, 46,593 scans in 25,184 patients were included in the analysis. And the incidence of CA-AKI in the development cohort was 5.8%, and in the validation set, it was 5.6%. We looked at whether certain baseline characteristics were associated with contrast-enhanced CT scans in the development and validation sets. And we found that older age, having an underlying hematologic malignancy, outpatient diuretic and ACE and ARB use, lower baseline EGFR, lower serum albumin, lower platelet count, proteinuria on baseline urinalysis, comorbidities like diabetes mellitus and heart failure, and higher contrast media volume were associated with CA-AKI. This shows our final multivariable model for CA-AKI in the overall sample, and the strongest predictors for CA-AKI were CKD stage 4 and 5, as well as serum albumin less than 3 grams per deciliter. all of the variables that were significant in this overall sample were also significantly associated with CA-AKI in the development and validation sets, aside from hematologic malignancy, which was not significant in the validation set. We then assigned points to each variable associated with CA-AKI, and CKD stage 4 or 5 and albumin less than 3 were assigned the most number of points at 13 apiece. This figure summarizes the frequency and cumulative frequency of CA-AKI stratified by risk category as defined by the risk score in the development and validation sets. In both sets, the frequency of CA-AKI progressively increased with higher risk score categories. For example, CA-AKI occurred in 2.2% of scans with the lowest risk category, which was a risk score less than or equal to 4 in the validation set, and then CA-AKI occurred in 32.7% of scans in the highest risk category, which was a risk score greater than or equal to 30. These are the ROC curves for the risk score in the development and validation sets, and the C statistic for predicting CA-AKI was 0.74 in both sets, and the Hosmer-Lemeshow test indicated that the risk score was a good fit with a p-value of 0.4. And so just to summarize our key findings, we found that CA-AKI occurred after 5.8% of 46,593 contrast-enhanced scans performed in patients with cancer at 3 academic medical centers. We identified a number of key risk factors for CA-AKI, including hematologic malignancy, diuretic use, ACE-ARB use, CKD, low serum albumin level, low platelet count, proteinuria, diabetes, heart failure, and higher contrast media volume. The lowest risk category was associated with a frequency of CA-AKI of 2.2%, whereas the highest risk category was associated with a frequency of CA-AKI of 32.7%. Our risk score showed good calibration and discrimination, and our hope is that this model will enable radiologists, oncologists, nephrologists, and other providers who care for these patients to identify those that are at highest risk for CA-AKI and thereby implement appropriate preventive measures. Thank you very much.